Assalamualaikum warahmatullahi wabarakatuh and good day to everyone. Welcome to Perak Trauma Life Support 2022. My name is Farah. I'm emergency physician from Hospital Seri Manjung. Right. My topic for today will be initial assessment and management of trauma patient. Okay. Okay, the objective for this topic is basically I'm going to talk about primary survey. Okay, how to perform primary survey, the initial resuscitations of trauma patients. Okay, and how to identify injuries in trauma patients. All right, and I'll be talking about secondary survey techniques as well. Right, these are just theories. You will be able to perform the primary surveys and secondary survey when you do your practical sessions. Okay, right. Initial assessment. Okay, so how to perform initial assessment in a trauma patient? These are the steps. Number one is your preparation. Okay, preparation of yourself, your team, your equipments. Okay, triaging patients. Triaging patients is usually done in pre-hospital care. Okay, and in hospital setting juga masa the initial arrive to the hospital, right? Then the primary survey, we'll be doing your primary survey, resuscitation of the patient from the primary survey findings, okay, and then we have to perform adjuncts to primary survey, okay. By then, if you are in a trauma center in pre-hospital care or in district hospitals or in clinic kesihatan, okay, you need to consider whether you want to transfer the patient by this time or not. All right. Okay, we'll be talking about secondary survey. This is a head-to-toe examination. All right, and history taking. Okay, then we perform adjunct to secondary survey. Okay, we have to make sure that we continuously do our resuscitation monitoring, all right, and documentation, and make sure the patient have definitive care. Okay, so the first step is preparation. Right, preparation we have two phases. Okay, I will be talking about pre-hospital care and hospital phase. So in pre-hospital care, before you even arrive to the scene, the paramedic you have to know where is the nearest healthcare center that you can bring the patient to. All right, notify the receiving center. Okay, make sure you have your airway equipments ready. Okay, make sure you have your immobilization sets ready. All right, and make sure when you have assessed the patient and you have do the initial resuscitation, we transfer the patient rapidly to a healthcare center. Right. Hospital phase, all right. Even before the patient arrive, you have to prepare your team, okay, assign jobs to your team, okay, and then prepare your equipment, your resuscitation area, make sure it's clean, make sure you have your your equipments ready, ventilators, your intubation sets, your fluids is warm and is up and ready to go, right? And you can give your lab and your radiology teams a heads up. Tell them, we have a polytrauma patient coming, and please be ready to come to emergency department to do x-rays, okay? Right. Triage. All right. Triage is in pre-hospital care. Okay. Why do we do triage? Okay. For example, there's a polytrauma. Polytrauma ni ada dua. Okay. It can happen multiple trauma in one patient. Okay. Or you can have a trauma with multiple casualties. Okay, that is called polytrauma. So if you have multiple casualties, you have to do triage. You have to sort out which are the patients that needs immediate medical attention. All right, you go to that patient first. All right, triage them, rate, and then transfer them immediately. Okay, so there's a few ways to triage patient. You can triage patient based on the mechanism of injury. Right, say car versus motorbike. Okay, you expect the motorbike has a more severe injury compared to the patients in the car. Okay, go and see the patients in the motorbike first. Right, or you can use the Malaysian triage protocol. Okay, yang ini is the one yang red, yellow, green tu. Right, and usually we use it in the hospital lah. Right, or you can use a trauma score. Okay, trauma score, we have two, physiological score or anatomical score. All right, so cramps, revised trauma score or pediatric score is based on physiological findings. All right, AIS, abbreviated injury score, scale, or injury severity score is based on anatomical injuries. Okay, all right. So what are the injuries that you will be expect from trauma patient? Okay, these are the examples. Side impact, say the car is being hit from the side. Okay, so these are the injuries that you expect to happen. Contralateral neck pain, all right, cervical spine fracture, flail chest, pneumothorax, and so on. All right. What about rare impact? If you are being hit from behind, okay, what do you expect? You can have cervical injury, you can have aortic injury, you can have long bones injury, pelvic injury, right? Ejection from vehicles, this one lagi lah, from head to toe, you have to expect all the injuries lah. If the patient is able to give you history, okay, you have to ask whether the patient is being how far is the patient being ejected from the vehicle. Or you can ask your paramedic who is at the scene. Okay, ask the patient, is it a rollover? They roll over, the vehicles roll over, ataupun dia keluar daripada ejected from the vehicle and they roll over. Is there any death in the same vehicle? Then those are the things yang consider high impact injuries. All right. So these are the steps. Okay, when you have the injury, kita perform primary survey. Right, and we resuscitate according to our primary survey findings. Okay, make sure you evaluate your after resuscitation. Okay, and then continuous monitoring and documentation. Okay, then you perform your secondary survey and adjuncts. Right, re-evaluate again and optimize patients for transfer or for admission to the primary team. Okay. All right, primary survey. So, how to perform primary survey? Okay, paramedics who are at the scene, you have to do scene assessment. Okay, when they arrive at the scene, make sure the scene is safe for them before you go. All right, and then make sure the patient is safe, not in the middle of the road. Okay, pull them out of from the dangerous zone. Okay, and then the assessment that you have to do is ETHANE, ETHANE. All right, E is exact location. Right, where is it? Where does the trauma happen? Right, for example, there's a motor vehicle accident at kilometer 387. Okay, Lebuh Raya Utara Selatan. Okay, menghala ke arah utara. That is the exact location. So that you have to tell your MECC this is the exact location so that they can send the next teams, your assisting teams to the exact place. All right. Type. Identify what type of trauma it is. Is it a collapsed building? Is it a burning building? Is it a boat karam? Is it a bus jatuh dalam gaung? You have to describe what type is it. Okay. Hazards. What are the hazards that can happen in the scene? For example, lori minyak terbalik. Okay. So you would expect oil spills and fire can happen. Right? Or you have a collapsed building. So you will expect there might be a further collapse in the remaining building. Okay. Right. And then kita go to access. You have to tell MECC, okay, how to access to the scene. If it happens in a highway, okay, you will expect jam, kan? So you have to tell them the exact location, and then you have to tell, oh, okay, it is jam from this toll exit to this scene. So maybe they can use a different exit tool. Right, numbers. Numbers is number of patient. If you cannot see all patients, you have to expect you expect the bigger numbers. For example, in a car, all right, in a sedan car is 5, right? In a bus is 40 people. Kita expect yang the maximum numbers the vehicle can take. All right. Extra resources, right? You have to tell NECC what are the extra resources that you need. Okay, do you need extra ambulance? Do you need police to help with the traffic control? Do you need bomber to help you with extraction of a patient? Okay, you have to tell them. All right. Next, look at the patient's position and posture. Right, whether the patient is being thrown off far away from the vehicle, look at how far the patient fall off from the building, you think the building, how high it is, okay? And then look at the patient's posture, whether they are in prone position, whether they are in supine, whether they are able to sit up, okay? All right, state of consciousness, okay? Look at the patients in for paramedic, we advise AVPU because it's easier compared to GCS. All right, so AVPU A is for patient is alert, okay, able to respond, able to give, able to converse, right? V is only when patient is responding to verbal. When you call them up, baru they will respond. Okay. P is when they respond to pain, and U is when they are unconscious at all. All right. Okay. Behavior ni, you look at the patient's behavior, whether they are restless, whether they are irritable, ataupun they are calm and they can follow orders. All right. And number 5, look at for obvious injuries or deformities. Okay. So how to perform primary survey? Okay. Primary survey steps A, B, C, D, E. All right. A is for airway and cervical control. Right. B, breathing and ventilation. C is circulation and hemorrhage control. All right. D is look at the disability and neurological status. And E is when you expose the patient and you control the environment as well. All right. Okay. Airway. First is inspection. So look, listen, feel. There's no more feel actually in post-COVID era. Okay. There's only look and listen. And then it's from far. Look for any patient is tachypneic, okay, patient, look at the chest rise, okay, listen for any gurgling sound, listen for any stridor, if the patient is able to converse or not. All right. Mind you, when you have a life-threatening condition at any steps, you must correct it immediately before you go to the next step. Okay. All right. Airway obstruction, what are the causes? These are the examples. All right. The most common cause for airway obstruction is a floppy tongue. Okay, especially when patient is unconscious. All right. And trauma is blood and secretions. Okay. You have maxillofacial injury juga. All right. And then your mechanical blockade or partial airway obstruction. Okay. How to remove them? You can use finger sweep only one time. Okay, kalau tak remove juga, then you use your suction machine. All right. To maintain the airway, okay, when you open up the airway, you use your jaw thrust or chin lift. Okay, never use head tilt chin lift. Okay, jaw thrust or chin lift only. All right. And once you open the airway is patent, you have to maintain the airway patency. How to maintain the airway patency? You use your oropharyngeal airway if there's no contraindication. If there's contraindication for oropharyngeal airway, you use your nasopharyngeal airway. Or next step is you intubate the patient. Okay. If you can't intubate and can't oxygenate the patient, okay, use your you have to perform cricothyroidotomy. All right. Okay. When the airway is already patent and you have maintained the airway patency, okay, protect the spine. Use a hard collar, spical collar, okay, and provide oxygen to the patient. Okay. Next is performing assessment on breathing. Okay, the steps to perform breathing assessment is 4 steps. IPPA. Okay, so number 1 is inspection, palpation, percussion, and auscultation. You inspect for chest expansion, look at the patient's respiratory rate, look at the jugular venous vein, uh, look at the whether the patient has real chest or not, if it's equal chest rise or not. Okay, look for any open chest wound. Okay, and then look out for implanted objects. Okay, if there's any implanted objects, don't pull them out. Don't remove the objects. Just anchor the objects and then seal the wound. Please, when you have a look at the chest, look at anteriorly, lateral, and when we do the log roll, look at the posterior part of the chest because we don't want to miss out any injuries at the back. Okay, right. Next is palpation. Okay, palpate for subcutaneous emphysema, for capitis, tracheal deviation, any pulsating hematoma. Okay, and palpate for the apex beat as well. All right. Next is your percussion. Look for any hyperresonance or any dullness over the chest and auscultation. All right. Okay. So in primary survey, there are 6 life-threatening conditions that you have to diagnose and treat immediately. Okay, because if you don't treat these life-threatening conditions, patient will die within minutes. Okay, so what are the conditions? It's your upper airway obstruction, okay, your tension pneumothorax, massive hemothorax, open pneumothorax, cardiac tamponade, and tracheobronchial injury. Okay, so upper airway obstruction tadi kita dah settle. So the next 5 tu is what we are looking for in your breathing. Okay, right. So tension pneumothorax, it's when the air goes into the pleural space and then tak boleh keluar. Alright, causing the affected lungs to collapse. Okay, and then causing the venous return to be impaired. Alright, lepas tu the ventilation poor lah. Yeah. So what causes it? Any chest wall or parenchymal injury. Sometimes when we back too hard pun boleh jadi juga. Yeah. Right. What are the signs? Okay, patient will be tachypneic, the patient will be tachycardic, BP will be low, right? Poor perfusion, okay, and then you can have tracheal deviation away from the affected side, all right? You will have a hyperresonance on the affected side, okay? You can have reduced air entry on the affected side. Okay, so the diagnosis is clinical. Huh? You don't have to wait for a chest X-ray to diagnose a tension pneumothorax, right? Management. Immediate management is needle thoracosynthesis. Where to do your needle thoracosynthesis? In adult, it's in the safety triangle zone. In pediatrics, dia dekat second intercostal space, mid-clavicular line. Okay, the definitive management for tension pneumothorax is chest tube insertion. Okay, right. Massive hemothorax. What happened in massive hemothorax? So massive hemothorax is when you put your chest tube in and then immediately 1.5 liter of blood came out. Or 600 mils in 6 hours. It can happen whether 600 mils in 1 hour ataupun 100 mils in 1 hour for 6 hours, or it can happen 200 mils per hour in 3 hours. Okay? Okay. What usually happen is disruption of the pulmonary vessels, okay, whether it's penetrating or blunt injury. Right. Signs. Patient's tachypneic, BP is low, right? Poor perfusion. Lepas tu, SpO2 unable to maintain, patient is hypoxic. You can have neck veins to become flat. And then there's dullness over percussion. When you percuss, there will start dullness over the chest and then reduce air entry juga. Okay. So management. Rapid volume restoration. You give your 1 liter saline, you give your blood, all right? You give your tranexamic acid, okay, chest decompression, and then thoracotomy. Okay, the definitive management is your thoracotomy to stop the blood vessel, bleeding blood vessels. Okay, right. Next is open pneumothorax. What happened in open pneumothorax? It's an open wound where the diameter of the wound is larger than the diameter of your trachea. Okay, this causes the air goes into the wound faster than the air goes into the trachea. All right. So how to manage an open wound? Okay. Make sure the airway is patent. All right. Give oxygen. Close the wound using three-way seal. Okay. Wound and then insert a large bore granula. All right. You have to make sure your cardiac function. Okay, and transfer patient immediately to the hospital because An open wound sometimes can cause, it can become a tension pneumothorax juga. Open pneumothorax can become a tension pneumothorax juga. Okay, so definitive management is to insert a chest tube, okay, and surgical closure. Okay, all right. So this is an example on how to do a occlusive dressing. Okay, where you put where you close your dressing over 3 areas. Okay, so when the air cannot go in, but whatever air is in the pleural space can go out. Okay, flail chest. Flail chest ni is when the segment of the chest wall, okay, is fractured and discontinued, okay, and collapse. It's not moving according to the breathing, okay. All right, paradoxical chest movement, and also can cause a severe lung or pulmonary contusion, then can cause hypoxia. Okay, so what is the definition of flail chest? 3 or more adjacent ribs that are fractured in at least 2 places. Okay, so paradoxical chest movement is when you inspire, okay, the segment 2 will collapse. And then when you expire, the segment 2 will protrude out. All right, so the management of flail chest is basically make sure adequate ventilation and also oxygenation. Okay, hydration, okay, volume restoration and analgesia. It's painful because the ribs are moving around. You have to make sure you give adequate analgesia. Okay, right, cardiac tamponade. Okay, cardiac tamponade can be because of penetrating injury or blunt injury. Okay, the characteristic, the signs will be your back striate, okay, elevated JVP, okay, muffled heart sound and distended neck veins. Your pulse pressure will be narrow, your BP will be low, okay. Then the how do you suspect a cardiac tamponade? Okay, it's when it can be when you have a penetrating injury over the chest, or over the heart, you have to suspect maybe there's a cardiac tamponade. Or kalau tak ada pun, and it's a raised JVP, walaupun BP is low, but the JVP, the neck vein is distended. Okay, other signs would be your poor perfusion, you reduce urine output, patient can be having altered mental status, and muffled heart sound juga. Okay, all right. So in cardiac tamponade, as little as 150 to 200 mils in the pericardium pun can cause significant cardiac tamponade. Okay, so the management is pericardiocentesis and or open thoracotomy. Okay, open thoracotomy. Okay, so how to perform cardiac tamponade? Okay, at the moment we are blessed with ultrasound, so we will use ultrasound guided pericardiocentesis. But the typical approach can be, there's multiple approaches sebenarnya. You can use your Z-Sternum approach, okay, 45 degrees towards your left shoulder, all right, or you can use apical approach, or you can use direct approach. Okay, next we go to the circulation. When you assess circulation, the first thing you have to do is look for any external bleeding. Okay, any exsanguination, hemorrhage outside. Look at the limbs, look at the abdomen, look at the head. If there is bleeding externally, you have to stop immediately. Then barulah kita pergi tengok the skin color, look at the skin temperature, peripheral skin temperature, look at the pulse rate, look at the BP and the CRT. All right. Okay, so major bleeding internally will be your chest, your abdomen, your peritoneum, your pelvis, and your long bones. When you have stopped the bleeding externally, then we look for the bleeding internally blocked. Okay, so these are the places where you can look for the internal bleeding. All right, so how to stop your bleeding? There's 4 steps. Number 1 is direct compression, directly compress on the wound. Okay, number 2 is elevate the wound, elevate the limbs, okay, affected limbs. Okay, number 3 is you compress the artery that supply the areas. Okay, and number 4 is your tourniquet. All right, don't forget to put in 2 large bore granulas. Okay, and then you start with your initial fluid resuscitation, 1 liter of warm saline, and then you ask your CFO and your blood transfusion cepat lah. Okay, and tranexamic acid juga lah, within 3 hours of your injury. Okay, assessment of disability. Okay, disability is basically a simple neurological evaluation. So your GCS, your pupillary reflex, your pupillary size, and your just a bit of limbs assessment, neurological limbs assessment. Okay, all right. When you expose the patient, all right, you have to thoroughly examine the pelvis, groin, genitalia, and the back. Okay. Mind you, when you expose patient judiciously, discreetly, okay. When you have to look at the lower part, just expose the lower part, close the upper part. Okay, when you have to expose the upper part, make sure you close the lower part. Okay, respectfully lah, all right. And by doing so, prevent hypothermia juga. Okay. All right. What are the adjuncts to primary survey? Okay, ECG, SpO2 ni semua lah. Make sure you have to do it. Okay. And by doing all this, kita akan dapat results for secondary survey nanti. Okay. If you are not in a trauma center, klinik kesihatan, or in district hospitals, do not delay transfer. Okay, do the initial resuscitation. Okay, do the initial investigations. All right, and then transfer the patient. Okay, all right. Secondary survey. Secondary survey, history-wise, kita ask the ample punya history tu, any allergies, all right, any previous medical histories, all right, if the patient is on any medication, all right, any surgical histories, all right, when is the patient's last meal, and what is the event that leads to the trauma. Okay, and then we will do a head to toe physical examination. All right, kalau you tanya it's from the hujung rambut sampai hujung kaki lah. Basically all, must you look at the oral, you look at the orbital, you look at the ENTs, you look at the fingers, the tail, toes, the nails and everything. All right. Okay. So when we do secondary survey, okay, what are the potentially life-threatening injuries that we need to detect? Okay, ada 5 ni pulmonary contusion, myocardial contusion, okay, aortic disruption, the diaphragmatic injury, and esophageal disruption. Okay, how to detect them? Just briefly. So when you do your chest X-ray, you'll be able to see your pulmonary contusion, and at the same time, you will see if there's any widening mediastinum for your diaphragmatic injury, for your aortic disruption. Okay. You will be able to see diaphragmatic injury in your chest X-ray juga, kan? Alright. When you do your ECG in primary survey adjunct too, you'll be able to detect myocardial contusion. Okay, right. And in chest X-ray also, you can see a patient has subcutaneous emphysema, or mediastinal emphysema, then can be esophageal disruption juga. Alright. Okay. So once you have done primary survey and secondary survey, okay, don't forget to document the findings, okay, and document the resuscitation, the treatment that you have initiated, all right, and then make sure once you have initiated the treatment, re-evaluate the patient, right? For example, you have inserted a chest tube for tension pneumothorax, okay, document what is the SpO2 afterwards, what is the the inspection, palpation, percussion, and auscultation finding post chest intubation. All right. in a patient with open pneumothorax, what is the chest X-ray after insertion of chest tube? Okay, re-evaluate and document. All right, so that's it. If you have any questions, all right, you can email me, all right, farahalwi23@gmail.com, or you can ask the facilitator during practical sessions with you. All right, thank you.